Hello. So the topic we'll be discussing is abdominal aortic aneurysms. So this presentation will involve its pathophysiology as well as risk factors and a management of AAA. This will be in related to a case study that I'll be mentioning later. So to begin with, what is a AAA? It is a persistent, irreversible, and localized weakening and dilation of the abdominal aorta, and it should be enlarged at least 150% for it to be considered a AAA. The pathogenesis of a AAA is complex. It involves multiple biological processes which trigger and exacerbate one another, as well as several modifiable and non-modifiable risk factors which lead to its formation. So these processes involve inflammation, vascular smooth muscle cell apoptosis, oxidative stress, and activation of proteases. Now, starting with the inflammation, this can be triggered by smoking, infections, thoracic trauma, or any chronic inflammation diseases such as diabetes or dyslipidemia. This then leads to the release of cytokines, which can directly induce vascular smooth muscle cell apoptosis, as well as induce the production of more oxidative stress. Now, this oxidative stress has similar triggers as well to inflammation. It also induces VSMC apoptosis, as well as induce more inflammation. And it also activates metalloproteinase, or MMPs. And these proteinases then directly degrade the extracellular matrix, and this is composed of elastin and collagen. Now, with these processes present, the decreased VSMC, infiltration of pro-inflammatory markers, and direct extracellular matrix degradation by the proteases, there is a loss of elasticity and resistance in the aortic wall, leading to the vessel becoming progressively eroded and weakened, dilated due to hemodynamic forces, and eventually rupturing once pressure cannot be tolerated or if there is trauma present. So I have some of the risk factors here. We've got genetics and ethnicity. So mostly non-Indigenous and Caucasian people suffer from a AAA, and this could be due to the dietary factors. We have age and gender. So over 75 due to decreased healing abilities, increased inflammation with the comorbidities, and we've got increased suffering people in males. We've got smoking, infection, trauma and comorbidities, including atherosclerosis, hypertension, dyslipidemia, and diabetes mellitus. And this is all due to the increased inflammation as well as the increased pressures within the vessels that increase the dilation. So our case study, we have Fred, a 67-year-old male with a history of hypertension and a current diagnosis of an abdominal aortic aneurysm. So talking about management of AAA, whether it's ruptured, symptomatic, larger than 5.5 with a rapid expansion, it is all recommended that they go under either a endovascular aortic repair or an open repair surgery. Now, before this surgery, or whether it is decided that surgery is not an option, these AAAs, they usually continue to enlarge. So what we are trying to do is limit the rupture risk and limit the expansion rate of this AAA through some drugs. Pharmacological management of AAA basically involves cardiovascular risk reduction, and it includes antiplatelets, statins, and antihypertensives. This, however, does not limit the expansion or reduces the size of the AAA, but it reduces the risk of rapid expansion and the risk of a sudden rupture, and it improves the overall health outcomes. Now, due to our friend here, Fred, having hypertension, I've chosen antihypertensives. So the overall conclusion with this is that the available clinical studies do not confirm the effectiveness of beta blockers or ACE inhibitors as strategies. And at this point, we are just looking at the potential for type 1 angiotensin receptor antagonists, telmisartan, for reducing these risks. So the drug I've chosen is telmisartan. It is an angiotensin 2 receptor blocker. So it causes the inhibition of the action of angiotensin II on vascular smooth muscles and the secretion of aldosterone, ultimately leading to the reduction of blood pressure. So here I have the renin-angiotensin system, which is one of our compensatory systems for blood pressure. When blood pressure drops, angiotensinogen is released, converted into angiotensin 1, and then converted into angiotensin 2. And angiotensin 2 then causes vasoconstriction in blood vessels and also causes the release of aldosterone, which stimulates reabsorption of sodium and water. So both of these mechanisms, vasoconstriction and reabsorption of water, basically increases the blood pressure. And by blocking that, we are inhibiting the increase of blood pressure. The primary indication for telmisartan is to decrease hypertension. It is also used for heart failure and diabetic nephropathy and prevention of cardiovascular events. There's also studies saying that it can help in diabetes as it aids in the metabolism of carbohydrates and lipids, which ultimately would also improve the prevention of cardiovascular events. So how does this relate to Fred? As Fred, he has a triple A and as well as hypertension. And one of the managements of triple A is basically the management of cardiovascular risk factors. So by controlling his hypertension, we are decreasing the risk of rupture and potentially decreasing as well the rate of expansion of this triple A. And this is by decreasing the hemolytic pressures and forces that dilate the aortic wall. So some of our nursing considerations is basically setting a blood pressure target. Well, the doctor would most likely do that, but it's our job to implement this blood target as well as educating Fred about this. Monitoring his blood pressure pre-medication just to ensure that we are not dropping his blood pressure too much, and as well as so we know that we are implementing the medication within a timely manner, and also taking his blood pressure post medication so we can ensure that the medication is working and that we are within the blood pressure target that we are aiming.